Hi, I'm Oliver Corneli from the University of Cologne, infectious disease physician and hematologist. Today's YouTube video is on Transdiaphragmatic Mucormycosis, and it actually refers back to a clinical infectious disease journal paper from Philipp Köhler. So let me take you through that. Before I do so, this is my transparency declaration, and today with this video we have another disclaimer, and that's the one of Oxford University Press, the publishing house of clinical infectious diseases, and just referring to the article where Philipp Köhler from my group published the information that are content of this video. Transdiaphragmatic mucormycosis, so that is a mouthful of a word, and we were actually sitting down and were contemplating on how do we just name what we saw clinically. And clinically here means that we were four on that team, four different disciplines. Philipp Köhler is an intensivist and infectious disease expert. Then Robert Reimer is the radiologist on the team. Roger Waber is the visceral surgeon, and you will see in a moment why we need all these different disciplines and departments of our hospital. And Birgit Schömmick-Markiewka is the pathologist. And well, Oliver Corneli, that's me. Mucormycosis, certainly in hematological malignancy patients, is usually confined to the lung. It might disseminate, but usually it primarily causes extensive necrosis in the lung. And dissemination, if it occurs, would usually be following blood vessel invasion, and then from there dissemination throughout the body. And usually that only happens in patients where as soon as you realize that, then the patient usually dies that same day or within hours. So we found a different pattern like others in patients who are at risk because of diabetic ketoacidosis, where usually it's not the lung, but it's a renocerebral process, and it might invade into the eye. So several organs are by default practically involved, but the basis for that devastating disease is diabetic ketoacidosis, and in these we know that contiguous spread through organs and through bone and maybe all the way into the brain. So we observed something strange and did so during a retrospective chart review of all 27 mucormycosis cases that we had at the University Hospital of Cologne between 2011 and 2019. 3 out of 27, so more than 10%, had a contiguous transdiaphragmatic disease. And there are two ways how that can happen in our experience, and I'll come back to that and the respective images in a moment. And mucormycosis in all these cases was confirmed by histology, plus minus and or culture methods. And imaging studies that we did were all contrast enhanced and usually chest or abdomen CT, so computer tomography. Let's have a look at the patient characteristics of these 3 out of 27 patients where we observed transdiaphragmatic mucormycosis. Patient number 1 had a B non-Hodgkin lymphoma, underwent allogeneic stem cell transplant, so one would accept that is a typical risk factor for a mucormycosis. Patient number 2 had AML, acute myelogenous leukemia, same thing, typical risk situation, high risk for invasive fungal infections. Patient number 3 is somewhat different. He does have an IDIM, an insulin-dependent diabetes mellitus, but as you expect, that was contiguous spread, but not renocerebral, but between lung and abdomen. Another aspect that I'd like to highlight, and that's where the next red arrow appears, is antifungal treatment. Apart from surgery, these patients underwent antifungal treatment with high doses of liposomal amphotericin B. So patient 1 received 10 milligrams per kilogram, and in patient 2 that was not the case. That patient was already on 3 milligrams when we realized that this is a mucormycosis. So we increased the dose to 7 milligrams. Later, due to toxicity, had to reduce it again to 5, but we never go below 5. And that is actually doses 5 to 10 or 10 to 5 that are currently being advised by the mucormycosis guideline of the ECMM and the mycosis study group. The third patient actually wasn't treated because he was in a terrible condition once the diagnosis was established, and he never underwent surgery or antifungal treatment directed towards mucormycosis. Another and last item that I'd like to point out on this table is just to announce that there are, with the full paper of CID, links to 3 videos of these 3 patients. It's the CT scans where you can just scroll through the CT scan the way you know that from from your hospital practically, I guess. Histology. That's the 2 patients who underwent surgery. On the left-hand side, it's a liver tissue sample, and on the right-hand side, it's a spleen sample, or a part of the spleen, which was, of course, completely removed when the patient underwent splenectomy. And on both, you can nicely see the pathogen. You see the broad ribbon-like structures, which are the #1 phenomenon in these patients that tell you this is not aspergillus, but this is mucormycosis and needs a completely different treatment. Coming to the imaging studies, not the videos, they are online with CID and you can just have a look there, but the 3 patients on one slide. On the left-hand side, patient #1, the red arrow indicates where the process extends from the lung through the diaphragm to the liver, and that is why we call it Transdiaphragmatic Mucormycosis. In the middle panel, you see exactly the same, but now it's on the left side, and there the disease extends from the lung into the spleen, again through the diaphragm, and almost reaching the kidney. And on the right, the third patient, it's a lung and liver case again. That already brings me to the conclusions of that small video on transdiaphragmatic mucormycosis. There are 4 of them. #1, this is a newly observed and reported disease pattern for us. We were astonished not to find it in the literature. You must have seen it, or it must have been in patients around the world. Maybe we missed it in other patients, maybe you missed it in your patients. It's not infrequent, 11% of our patients. So we only found it when we reviewed all the patients systematically. Maybe that is an approach that you, if you treat these patients, want to follow as well. And clinicians should be really aware of this possibly really underreported entity. And mucormycosis guideline, the current and upcoming one from the One World, One Guideline program of the ECMM, where mucormycosis is being done together with mycosis study group and their Educational Research Council, they now recommend staging using CT or MRI. And well, the last thing to point to hint at, is check out the really impressive CT videos that Philip did and that are published together with the article on Clinical Infectious Diseases website. So thank you very much for tuning in with our YouTube channel Infectious Diseases in Motion. I hope to see you next time again. In roughly 2 weeks there will be another video. Thank you very much and tell your friends. Goodbye.